Hi, my name is Katja Weisel. I'm working at the University Medical Center of Hamburg-Eppendorf in Hamburg in Germany. And I was very happy to present in behalf of my co-authors at this year's virtual ASH meeting a poster about Carfilzomib twice weekly in combination with dexamethasone and Daratumumab, the so-called KDD regimen, versus Daratumumab in combination with 8 cycles of Bortezomib and dexamethasone, the DVD regimen, as an indirect matching adjusted treatment comparison. Why did we do that? We all know that lenalidomide is playing an emerging role in first-line treatment of multiple myeloma, so that we generate more and more patients coming out lenalidomide pre-exposed and even refractory out of the first-line treatment. So there is a growing and unmet need for lenalidomide-free regimens from first relapse on. And the KDD and the DVD regimens are len-sparing regimens combining the monoclonal anti-CD38 antibody strategy with a proteasome inhibitor and dexamethasone. And we aim to compare KDD and DVD according to the phase 3 approval trials introducing those regimens, the CANDOR and the CASTOR trial, using a matching adjusted indirect treatment comparison. The first thing was to match completely the patient population of the two trials, the CANDOR and the CASTOR trial. And here you see that the patient population was quite different. And so we had to take out the equivalent of the CASTOR population out of the CANDOR population. And then we aligned the patient selection criteria, and then we are using this methodology to focus on progression-free survival first. So first of all, we did this matching procedure with minimized differences in observed baseline characteristics between the two KDD and DVD populations, and now you see the result of the KDD matching a population. So patients refractory to an PI were removed, and we reduced the KDD sample to 82 patients. With that, we could do the comparison of DVD and KDD. And here we see that treatment with KDD reduces the risk of progression or death by 39% overall and 64% after 8 cycles. And you see that the curves clearly differ from the DVD curve. And this is for both the KDD unmatched and matched population. Compared with DVD, treatment with KDD reduced the risk of progression or death by 54% overall and 65% after 8 cycles in Bortezomib exposed patients. You see these results here. And this is especially of importance because in the DVD regimen, Bortezomib dexamethasone stops after 8 cycles. So this was the reason to do this analysis, showing that the continuation of the proteasome inhibitor allows a much more effective and durable treatment. The progression-free survival was more favorable for KDD versus DVD in lenalidomide exposed and lenalidomide refractory patient subgroups, and this is very important, as I said, that lenalidomide has an emerging role in first-line treatment. For sure, there are some limitations, although this approach is in accordance with methods guidance. The matching adjusted results are associated with inherent limitations due to the decreased sample size for KDD and due to known differences such as longer follow-up for DVD or unobserved differences in the trial. We did no comparison of overall survival. But in conclusion, we clearly state that this present analysis suggests that KDD improves outcomes compared with DVD in patients with relapse and refractory multiple myeloma, as KDD was associated with a substantial reduction in the risk of progression or death compared with DVD. And this was 39% overall and 64% after 8 cycles. These results were consistent, independent of patients being lenalidomide exposed or refractory, so that we can clearly say that KDD is again confirmed as a novel standard of care for patients from first relapse on, especially after pre-treatment with lenalidomide. I thank you for your attention.